All right. Hello again. Welcome to the Down Fracture Podcast, a podcast for talking jaws. Um, as we mention every week, feel free to email us any topic suggestions, cases, anything like that to downfracturepodcast@gmail.com. Any insults towards Sam are also appreciated, like
Yeah, I don't
last
think we
week.
got any last week, so that's good.
Yep.
Did you do your makeup this week?
I disregarded your email, Evan.
So no makeup artist. That's a no-go. Um,
It's good to be here. We got a guest today.
we do. You want to introduce
Um,
our guest?
yeah, I think I'll do that. This is Evan. Evan is a biomedical engineer. He has about as much experience planning orthognathic surgery as anyone. He started working for a reputable corporation in the 3D planning world in 2014. So he has at least 10 years of driving orthognathic surgery plan experience. So I'm quite confident that you have more experience planning orthognathic surgery on the digital side than Dr. Wasson or I do. That's fair, right?
That's fair.
What's your number of cases, just ballpark? Have
12,
you
12,000.
12,000 cases?
Yeah, somewhere in that ballpark.
So yes, it's a very huge number if people are new to this. So we're talking about 3D planning today, orthognathic surgery from different perspectives. So from the surgery side, which I think we'll weigh in on, but also on the engineering side, which it's nice to get Evan's viewpoint. So Evan, how was your weekend, man?
I was actually in Palm Springs for the cosmetic surgery meeting.
What were
It
they
was,
talking about down
it
there?
was 80 degrees, a lot of cosmetics, not a lot of jaw surgery.
A little jaw surgery?
Elda Fisher spoke about facial feminization. I think that was one of the only topics on jaw surgery, which was surprising to me, but it was
Uh,
good nonetheless.
Those are good guys. They should talk more about jaw surgery. But
I,
let's see. Wasson, what we were just talking about some inside info on the engineering side. So
Yeah.
how do we jump into this, you think, Evan? On the topic of 3D planning, I know the process pretty well because I've been working kind of since the beginning of 3D planning on the different processes and workflows. But I think for most people getting into this, they see 3D planning of jaw surgery to be something that you upload to a company, and then you have a meeting with an engineer, and you guys come up with a plan to carry out a surgery. Is
yeah,
that's how it's generally done these days, Evan?
yeah, that's the general flow of things. A lot of ins and outs before and after that session, but that's what you're looking at.
So from is it always done the same way?
Done company to company or surgeon to surgeon?
Yeah,
No, probably not. I mean, yes and no. Yes, I can't speak to all of the companies. Say
sure.
surgeon to surgeon on the front end is going to be the same. On the back end is probably a little bit different.
Okay, so front end, what you're talking about is getting the data ready for the
Yeah,
planning.
yeah. So
Uh,
I feel like, well, I think I'm speaking for most companies where they're very siloed off. A team of guys that are girls, gals that bring data in, a team that actually goes in and segments it. So we get what Dr. Wasson has up here on the computer. So process out CT data to get bones and soft tissue and nerves. And then a team of people who will actually take those dental models and align them to the CT scan. And then another team that is going to be the clinical facing team that's actually going to meet with you as a surgeon.
Because from the provider side, what we upload is some tooth level info, some bone level info. So see or cone beam frequently and an STL for an optical scan.
Yeah.
And then we have a meeting scheduled in the future with you.
Yeah.
And so what you're speaking to, like, there's a delay in those two data points
So
because there's a bunch of
data
work that gets
receipt,
done.
yeah, to meeting is some X period of time, and all of that stuff happens in that window of time.
Okay, so whether that's a week or two or something. And so the companies get all the data ready for the meeting. And when you jump on, um, it's what our experience is, which we just talk about moving the occlusion and the bones to the right spots.
Yeah.
Um, and so the way things are set up, is that always the same?
More or less. I mean, it's going to be, I'd say the steps that happen before are going to be the same when it comes to the actual planning session and setting an occlusion and setting head position. That's all something that's, I'm not going to say it's done arbitrarily, but it's kind of done within a set of specifications to then later be discussed with the surgeon.
Because
You know,
I
so,
remember talking to a fellow, this was a few years ago, and he was trying to come up with, or not trying, but he came up with a protocol to um, standardize the steps of 3D planning. Because I just kind of take for granted that there's standard surgeon steps. Is there standard engineer steps? Like you guys have like a sheet of paper is like, hey, we got to go through these 12 things, and then you just drive the surgeon through it.
speaking on like planning sessions specifically,
Yeah.
I would say we'll say yes. There's kind of you train people to hit these say these 6 high points. So head position, cant, midline, AP, vertical, occlusal plane change. Um, but then you get surgeons that jump on and are like, all right, 8 forward, 6 up, 8 counterclockwise, then it all gets derailed. So you never really know.
Got it. So if you're a new guy like Wasson's doing his we're gonna plan with Wasson right now, let's say, right? He uploaded his data that you got here. Um what's like your ideal situation of working with the surgeon? Like if you know, if it's gonna go well for you, how does he approach it?
Yeah. So surgeon that knows what they're doing actually knows what patient it is. That's big number one. You'd be surprised how often you get on and they're like, all right, who is this? And you spend 15 to 20 minutes trying to figure out who it is before you start treatment planning.
Being ready for the planning session sounds like a useful thing.
Yeah. And there's, I feel like you guys have spoken on head position a few weeks ago. There's, well, as an engineer, you'll set it up in what appears to be the best skeletal head position, a level orbit, set it up into Frankfurt, drop a mid-sagittal plane right down through Nasion. But that might not be how someone holds their head. You look at somebody's soft tissue and their midline's not lined up with their skeleton, and then what do you treat to? And if you just go based on the engineer's recommendation, might you be correcting that the wrong direction or fixing it wrong?
Evan, do
Maybe.
people send you head position data anymore? They
No,
used to send
it used to be the
gyroscopes and
gyroscope data. That hasn't happened in 10 years.
laser level
Maybe. I think when yeah,
opaque markers.
I think when you got out of fellowship, that kind of went away. For
Clinical pictures.
Clinical pictures are an underutilized tool, in my opinion.
Okay.
It's you have them on your side. Very few people send them to their planning company or whoever they plan with. So that's something that, okay, you can immediately look at this. I mean, clinical pictures might not tell the whole story, but it's a better place than just a CT scan where somebody has their head tipped like this and you're trying to reorient that into a good position.
Yeah, because Mike, you thought that you just jump onto the meeting, it's always the same, yeah?
Yeah, I would say that. And so I think there's a couple things that I've learned talking to Evan, and I've learned along the way that I think it's just nice to pause and point out. And you hit a couple of them, and that's one, it's not the same person who takes on your case and they see your case from start to finish. And I think that's something people probably don't know. I don't think they realize that the person they're speaking to, the engineer they're speaking to, might have had absolutely nothing to do with setting up the case. They're just coming on to speak to you with the end product and then work with you. I don't think people probably know that. And I think they probably also don't know, kind of, I didn't know that you guys would even want clinical photos. Like, I can't recall an engineer ever asking me, for those things, like when they send out a planning session invite, like, hey, do you have any clinical photos that would help? Like, I'm not even sure I knew I could send them.
Yeah.
You how to upload your STL file into a zip file, and you know how to, upload your CBCT into a zip file and send them along. But I don't know. I mean, I guess there's nothing stopping you from sending a JPEG or, another photo type there. But I mean, I would I would have sent those every case if I thought it would help you guys out. And so I think that's a tidbit there that maybe people don't know. And then again, I think it's nice to emphasize that you guys are just doing the best you can. And like, I think too many surgeons they show up to that meeting and they're like, this is right because this
Yeah.
engineer did it and they know what they're doing. And that's not necessarily true.
Yeah, historically, I think in the age of analog, we'd get a box with dental models. We get a box. In that dental model box would be like folded up clinical photos and a Ceph tracing. But
Yeah.
as things have moved digital, that's just poof, gone out the window, and it never really picked back up. And instead, you rely on a conversation to suss out, natural head position, which oftentimes can work just fine, but oftentimes it doesn't work as well. If you're out and about trying to do a planning session, you don't have those photos right in front of you.
And
Yeah.
how long did it take before you realized surgeons are very different in terms of how they carry out their plans?
Almost immediately.
And your initial training was how many cases before you were planning with the surgeon?
It's pretty extensive. I'd say
Roughly.
from the minute you get hired on average to the minute you're talking to a surgeon is 6 to 9 months.
Okay.
Wow.
So it's not, you're not getting on with somebody that doesn't know what they're doing. They're very proficient in the software. Are they very proficient in, the clinical side of things? Maybe not. And that's kind of something that's very hard to teach an engineer in a business of engineers. Someone that's been there for years is, and especially when you're getting influenced by very different surgeons. It's like you get exposed to someone like Dr. Bobek, and then you get exposed to someone that's we'll say older and more traditional in their approach to treatment planning and surgery, and trying to accumulate that information and make an opinion on what the maybe correct or incorrect thing to do is difficult.
Yeah, because I think that would be hard, like going in an engineering job and realizing it's as different as it is. Because I think I'm always surprised by how different treatment plans are from surgeon to surgeon.
Yep.
Because it seems like there would just be one correct answer. But it really just depends on what they're comfortable carrying out and how they view the problem and, the reason the patient's doing the surgery and all that sort of thing. And so from an engineer side, I think more information is good for me to hear. I mean, because you have so much experience, you're speaking to things, I think, in a similar way to what I'm speaking to it. But when you were training new engineers to come in, what did you see that they were kind of struggling with, or what do they need, you think?
That's a hard one. You never really want somebody that's just starting to recommend things. I think as a treatment planning company, you kind of shy away from suggesting things, right?
Yeah, for
It's
sure.
like it's not your job. We offer the service of manipulating the software, not of telling you how to treatment plan your patient. But
Yeah,
there's things that say a newer surgeon met with you, jumped off a treatment planning session, you expanded maxilla 15 millimeters, you advanced the sagittal split 18 millimeters. It's something it's big, but you're comfortable with doing that, right?
yeah.
You get on with
Not too weird.
right? You get on with someone else and they're like, okay, let's do this movement. And you're like, okay. And then you see a Sag that's coming forward 11. And to them, that's a lot. To you, you're like, okay, well, I just got off this guy up in Seattle who said it was just fine. You don't bring that up and then come to surgery. This person's like, well, I was not comfortable with that. It's like, okay, well, I didn't know that I was supposed to bring this up to you as being too big a movement. And that's like how widely varying all these different surgeons are that might meet with a
Yeah,
company.
because I mean, like for me, it was really an important thing, and it still is important for me to plan with someone that I can kind of talk to and understand, and they can talk to me and understand, or at least like to some level that we're talking about the same problem. But I think more often than not now, just because of, volume and case, the different corporations that do it now, you don't really get connected all that much. You think that's fair?
Austin and I were talking about that before, where he previously doing more volume had a consistent engineer or two, and I think that makes a world of difference. Both, honestly, from both sides. Somebody
Yeah.
coming from industry side, it's like, okay, I know this guy, I know what he wants. I can kind of go through the motions for 30 seconds before we jump on and kind of get sub prepared because I know what to expect. And then that this person, as a surgeon, that this person knows what you're comfortable with, what you're not comfortable with, kind of what red flags to bring up to you surgically that might cause some issues. And it's hard to get that unless you build that relationship with an engineer. One, just knowing they're competent, and two, just them getting to know you as a surgeon.
Yeah, because I mean, I think everybody on team, it's important to have some rapport with, right? I mean, I feel like, kind of breaks down barriers. And I plan with different companies, and I generally see that as a bit of a barrier. Like I don't really know the person I'm meeting with. And it kind of takes me a while. Wasson, what do you think? Are you able to meet up with people in Arizona where your planning company is located?
Yeah, I mean, because I kind of split it now, like similar to what you're describing, where I do a lot of it on my own in-house and then do some with the planning companies that it's tough, like you're saying. I feel like they do a reasonably good job of knowing the basics, like the stuff that you could rubber stamp of, oh, they have a file of what kind of splints you like and sometimes what images you want on your report and things like that. But as far as the actual planning, yeah, it's tough if you don't really have any experience dealing with that person at times. And because they don't know you, you don't know them, you don't know if what they're trying to do is garbage, and they don't know if you're garbage, which I am.
Well, I mean, because Evan, is it really that? I mean, I know it's different, but is it that different?
But what?
Like, are the plans like? I kind of feel like there'd be different camps of surgeons in terms of how people are with planning. Some people that, like you were saying, have a relatively straightforward plan, like we're moving 10 forward, 10 up, 10 counterclockwise, and that's great. Versus, like let's say when we plan, I might be open to 4 or 5 different plans to segment things out in various ways to manage things in increasingly complicated ways. But you know what I mean? Like, is it that different? I
Oh
feel
yeah.
like probably 80% of people plan, they spend 10, 15 minutes on it. They're like, hey, that looks good enough. Is that how it goes?
Yeah, I would say yes as a general rule. And there's some people that are open to I mean, I'll call it optimization, where you get to the end, you see what it looks like, you're like, okay, wait, if I segment the manual, if I turn this into a 4 piece, it's gonna kind of be the icing on the cake. And I think a lot of, like, you can do it really easy on the computer, but I don't know if a lot of people are as comfortable with that
Are
as you
you
are
empowered to say stuff like that
as an
as an
engineer.
engineer? Yeah.
I, me personally, I think I was experienced enough that people would value my opinion enough to sell somebody on that. But if you got on with 9 out of 10, probably not. It's not something that would be brought up at the end, like, oh, hey, this could be better if you did it this way. Kind of like getting into the weeds like that, I don't think would be something that would be brought
Was
up unless you had a relationship with somebody. Then generally not.
Yeah.
See, I think that's an important thing to bring up, especially when you talk about segmentation of the maxilla, especially because, you know, not everyone. I mean, if you think about the process of people who are mostly using companies for planning, just as we've talked about, they send their files along. They're often probably not 3D printing models. They're probably not taking models to examine. They're probably not, looking at them ahead of time in any software. So a lot of times they're probably just saying, oh, okay, I think this is a 3 piece or a 2 piece. And that's the data and information that they put on their planning form. And that's what you get, Evan.
Mm-hmm.
And I think that's a huge point of disconnect right there, because you, as the engineer, from what I'm hearing you say, at least 9 out of 10, or most engineers, aren't even going to try a different setup. They're going to say, oh, they said 3 piece osteotomies between the sixes and sevens. That's what I'm doing. I'm going to get the best occlusion with that set of constraints that I can, instead
Well,
of maybe saying, well, what if we did do this as a 2 piece or a 4 piece? Because the surgeon's not doing that with models like they would in the olden days with model surgery.
yeah,
And the engineer's not experimenting with which of those would be better either. And I think, like you're saying, you're missing that huge step of optimization. And I think that's the right word.
yeah,
We could have done this better, but that disconnect right there, I think, is huge, because you're missing that step that would have been there with model surgery, potentially, or just examining tangible models in your hand like we had to do back in the day. I don't know. What do you think about that, Sam? Is that kind of what you were getting at?
Oh, for sure. I mean, I think there's a lot of benefits of kind of bringing this sort of thing in house, but kind of being involved in the middle of the plan, I think is helpful. Because I mean, when I used to plan with Evan, I took for granted that he would have an opinion on the best fit on the occlusion. And I wanted to hear if we're just making a 2-3 cut or 1-1, or we're doing what you're doing, which is apparently 6-7 cuts on your 3-piece, which is crazy. You're just doing a little first and second molar cuts.
No, that's just
I know
setting the STL,
No,
the
I know.
equivalent of the CT scan, which is an important step we should probably talk about too.
But I mean, I think in terms of I feel comfortable using the software myself, that I could get a reasonable feel on segmenting things in different ways. Which if you just upload your plan and then you say, hey, I'm planning on a 1-piece Lafort, BSSO chin, and that's the only thing loaded, you're not, I don't think you're really looking at the data as well as you could be. So
Well, here, let's just put it this way. No one is actually looking at, I think let's just, in the scenario we're saying, which is what happens probably 99 times out of 100, is no one is looking at the occlusion to really see how it would be optimized.
Yeah, and kind of taking a step back, I would say, speaking from experience at companies, it's like they'll look at it and kind of go through the basic 2-3 cuts bilaterally, 1-1 cut, maybe a 3-4 cut. But beyond that, it's not like they're going to say, oh, yeah, if you do 3-4 right, 5-6 left, that's going to get you. And I guess never is maybe misstating that. You get some people that'll look at that and make that happen, but that's kind of not, that's going to be the exception rather than the rule. And I think you guys, because you manipulated this a lot and are comfortable doing those osteotomies, know that that is an option and kind of an avenue to explore. But a lot of people aren't.
Yeah, also like what's good enough, right? Like,
Exactly. I mean, oftentimes a 2-3 cut gets you pretty close. So it's like, okay, that's good. Spin you around. You as a surgeon say, yep, that looks pretty good. But if you went down this rabbit hole of, oh, if we really tweak these osteotomies, we could make this a 10 out of 10 instead of a 7.5 out of 10, where 7.5 out of 10 is probably going to get finished just fine, but a 10 out of 10 obviously is a better result.
Yeah. So, I mean, if you're a new surgeon kind of uploading data, planning with an engineer, one of the things that I was surprised by is just the need for the relationship and the need to kind of run the different scenarios. And can you request that? Can like new guys request that you best fit the occlusion? Or
I mean, it's probably not something that's you're not going to get on as a surgeon and then the engineer has 5 different occlusions waiting for you. Probably.
For sure that doesn't happen.
Could that happen?
Never.
Maybe. Is it probably going to happen? No. But I mean, if you have the time, you can request to look through that and look through the fine tooth comb. But I don't think you're.
Well, what would it take to make that happen? So let me just back it up. So like should surgeons who maybe aren't sure, should they be writing stuff on the planning form such as, I want to look at this at a 2-piece, or I'm sorry, a 3-piece versus a 4-piece, or a 2-piece versus a 3-piece. Can we look at cuts here and cuts here? Like if they write that on the planning form, is that going to get done? And
probably a better chance than not, for sure.
so maybe that's something from an engineering standpoint that the surgeons could do a better job of. Sending photos, I think, was an interesting one that might help, that people should maybe remember. And then knowing that they can suggest or request that. I think, again, I think there's people out there who don't know.
I think that's the biggest thing is, and I don't know if soliciting feedback from the engineer, but just really look at it with them. And it's kind of a general rule that, hey, you have to confirm this occlusion with the surgeon. Like that's just something that we train people that you have to do. So you'll spin around it, but as you, while you're treatment planning as a surgeon, are you really looking at it that hard? And when they're spinning around, are you going to see if it could be better? Maybe, but maybe not. So I think it's not putting the onus on you as a surgeon, but just to question that and say, I think most of the engineers know teeth enough where you say, hey, could this be better as that cut? And they'll be like, oh, like, yeah, let's run the scenario real quick. And it's a few clicks of a button to tweak that. So it's, it's pretty easy to do.
What I generally was getting a feel on was because I like tweaking things, if I asked to change an interdental cut with certain engineers, it seemed like a very big ask. And I wasn't sure if they just were uncomfortable using the software or we were going to run out of time. I don't necessarily like planning for a long time, but
Yeah.
is the work split up so much that segmenting the data is something that engineers don't do?
Segmenting is in osteotomies,
Yeah,
then yeah, engineer will take care of that. That's
the
fine.
engineer does that
And
stuff.
I know for any company that uses Dolphin, it's very easy to switch. So to go, if you're staying within, say, a 3-piece, to go from a 2-3 cut to 3-4 cut is super quick. And to look at that,
Because
I can't speak about other softwares, but
if you want to say, let's pull the Dalpon a little more distal,
yeah,
let's do an inverted L on this side. I kind of got the not groans, but I got the feedback like, oh, this is going to take a while.
no,
Whereas in the past, it was quick.
yeah. Anyone that uses Dolphin, it's quick and easy. Anyone that got trained by me, it's quick and easy.
We don't have any ads for Dolphin, by the way.
We don't.
Got it. Okay, so engineers from the training side, it's not that big of a deal to switch.
Yeah.
Okay, cool.
But going to the Dalpon, I think that's another thing I don't know if underutilized is the right word, but looking at that's something to look at in how to reduce interferences or fix symmetry is how you can change even just the Dalpon, short split, long split, or if you want to go down the rabbit hole, inverted LIVRO, something like that is interesting, but is not often looked at. Maybe just a handful of surgeons that do such a thing.
I love what you're talking about. Moving the
Yeah.
Dalpon around is speaking my language.
Yeah.
I mean, I would add to that though. I mean, I can recall when I was mostly using, not planning my own, even if for a lot of that, even if I was going to do it, I wouldn't necessarily put it in the plan. You know what I'm saying? Like, who cares where the Dow Pont is from the planning is what I would say, because I know I'm going to make it up there. And as long as the occlusion in my splints are right, like I can make the Dow Pont or I can do whatever.
But what if you're addressing mandibular asymmetry? Like interference on a yaw discrepancy. You can design the mandible cut in different ways to influence that.
Yeah, I think it's more just to visualize, less.
Exactly. You're just asking for it to be on a piece of paper,
Yeah.
on an image when you're in the operating room, but like you don't need that to carry out the plan. Like you just,
Oh yeah,
that's what I'm
it's not like
saying
you're
is
getting-
like
yeah.
I wouldn't request that of the engineers, even though if I knew I was doing a modification, it was mostly plan the movements, get the splints, and then I know on the right side I'm doing this, on the left side I'm doing this, but it doesn't need to be on the piece of paper hanging up in the operating room that day. You know what I'm saying?
Yeah, but I mean, I think we both use plans nowadays and ways to like demonstrate to patients on what's going to be going on.
Yeah, for that it's great. But I mean, again, I think people who are probably using companies to plan their surgeries are probably not doing that, wouldn't you say?
I don't know. They should be, is what Evan was just saying.
Oh,
Evan,
yeah.
I mean, because it's not that big of a deal. It sounds like if they know how to use the software, then
yeah,
moving the Dalpon a little bit or adjusting the chin design a little, right?
Yeah.
And so,
it's just that some people, they just don't recognize that. Yeah, I mean, I don't know if it comes down to what their training looked like. Obviously, I haven't gone through residency and fellowship and opened up a practice, but it's like, oh yeah, you can move that Dalpon back a little bit, and that makes a difference in how you can auto rotate the proximal segment to level out the angles or fix the posterior borders or whatever that might be, reduce interference. It's just something they don't recognize, and they're like, all right, let's just make our cut how we always make it, and that's that. It's kind of a.
And so, from the 3D plan, to like, printed 3D printed plates or surgical guides, how's the timing these days on all that process? Is it pretty quick or is it a long deal?
Depends on the vendor. I think if you have, so if you're doing printed plates, it's at like 12 days or less. I don't think any vendor is longer than 12 days, but 12 business days. Yeah, it's like 2.5 weeks.
And that's a separate team from the 3D planning person for your surgical plan, right?
Not that will design your custom plates. Generally, that kind of falls under the same spectrum as surgical planning, but there's a team of folks. I imagine for most vendors, it would be this way. that handles guide design, and fabrication separately.
All right, Evan, you're not going to offend me. What do you really think about 3D printed plates?
they they have a they
They're
have a
great.
they have a place for some things as a tool that's used as the gold standard, up for debate, in my opinion. Sagittal split plates, I don't think have a place anywhere. LaFleur plates could be argued, chin plates could be argued.
You have indoctrinated him well, Sam.
Yeah, no, I
Basically
didn't.
regurgitated
I wasn't
your
even thinking the
opinion.
conversation was going to go there. I just, I think
To be
in
honest, I
terms
don't
of
think him and I have ever really had that conversation.
Yeah. Uh-huh.
Did,
Well,
did I offend the big dog? Is the big dog offended?
no, you basically I couldn't tell if that was you talking or Sam talking. It was
I do
the
feel very
same
much the same way.
the same thing. Well, let me if I'm trying not to steer this another direction too much, and Sam, if you wanted to go a different route, then pull it back. But I would be interested in, Evan, from your perspective, of what other things might surgeons not know that they could do to either improve their plans or make things easier for you. I think we've hit on a couple of them. Send photos. Again, I was oblivious to that. I hadn't done that since, as you said, when we were sending stone models in the very beginning, we would, sometimes put a Ceph or a photo or some things in there. So like attaching photos. What else could we do to make life easier for you or make the planning session go smoother, better, easier?
I think we kind of hit on all the big ones, really. Um,
Okay,
Being
then
prepared, having a plan.
yeah,
yeah,
I think
and
having a plan, knowing
having,
which patient it is.
having at least like a rough idea of your plan and what you're doing is super helpful. You'd be surprised when people get on and they're like, all right, so how much, me pretending to be a surgeon, like how much should we move the maxilla forward? Like, no,
Wow.
like
Yeah.
you're the one that's supposed to tell me this.
Well,
Like I can spit some numbers at you for cephalometric measurements, but I'm not going to say, yep, 12's the number. Um, which is interesting.
what other what other things do you think maybe surgeons don't know that they could utilize? I'll throw one thing out there that I didn't know for a while, and that's that you can kind of have multiple plans. So
Mm-hmm.
like in a circumstance that Sam and I have discussed, I don't remember if it was on one of these podcasts or not, but sometimes you are trying to make a big movement, and you're not sure you're going to get there. I'll throw this out of like, okay, if I plan this ideally, I've got to move the maxilla forward 15, 16
Yeah.
millimeters. Well, what happens if I'm in the operating room and I can only get it 13 or 12?
Yeah.
Well, then what do I do? So I think a lot of people don't know that they could, in theory, have multiple sets of intermediate splints.
Oh yeah.
Um,
Yeah,
and,
that's a
and
big
so I
one
think people don't know that.
for like cleft lip and palate cases and sleep
Yeah.
apnea cases. That's huge, and I think that's something that most engineers that are at least relatively experienced are pretty good about offering if they can sense some sort of hesitancy in the surgeon about getting it advanced as much as it needs to get advanced. But that's absolutely something you can ask for and is a very easy ad for.
So let's just make sure we're clear on that. So again, surgeons out there who are listening to this, in theory, if you wanted to make a big move, you wanted to move the maxilla forward 16 and you were doing maxillary first, you could plan that. And then if you were just wanting to have a backup plan, you could in theory have a second intermediate splint that you mark at 12 millimeters and then even another one at 10. And that way, if you got into the operating room and you weren't comfortable trying to stretch it to 16 or that didn't seem right, you could then instead use your 12 millimeter or your 10 millimeter advancement splint and plan. Your final splint should in theory be the same, but I think that's something that people don't know. Do you have any other little tidbits like that maybe people underutilize things
I,
that are available to them?
I want to jump in real quick on that one.
No.
Evan, I'm sure you have some more, but it doesn't have to be crazy numbers either. So, I mean, if you're stressed out about a 10 millimeter advancement in the maxilla or a transverse 10 millimeter increase, you can just have less than that and then have a backup plan. I think the one that I wanted to throw a shout out for is potentially choosing maxillary surgery first. So if you're uncertain on the scanned occlusion on a class 3 situation and you're doing some clockwise, instead of doing the normal mandible surgery first, having two intermediates and making the decision on the table is very
something
good.
That's interesting that for cases like that where maxilla first is going to be way advantageous from an intermediate splint position, but you're not sure about how they were scanned. we can give you that. I mean, I'm sure any company will do this. They'll give you
Yeah.
basically a bite check. So it's an
Yep.
initial splint based on where you plan that initial occlusion to be. You put them under anesthesia, you throw that in. If it fits, great. You articulate in and out, no problem. If it doesn't, then you have that backup mandible first, which might be
Well,
kind of unfair, but it's going to put you in the right place.
yeah, using some of the tricks to help you out in surgery for backup plans is a great idea. I love
But
that.
again, I don't think people know that. I don't think people know these things exist, or a lot of people know these things exist. And
Well,
it sounds like
good thing we're
it's
doing
as
the
simple
podcast.
as asking for them, because but I mean, a lot of these things have never been in my planning sessions.
And
I
if
don't recall them ever being suggested.
And I mean, if you get a more experienced engineer, they'll kind of pick up on that talk track and might suggest it. If you don't, probably not. You can always ask for it, and they'll most should understand what you're talking about and get that. But it's not going to be something that's a newer engineer's first line of thought to offer you,
Because
for better or worse.
Evan, there's errors in the engineer side, right? Like you've caught yourself being better at catching your own errors
And
as time
like,
goes on.
what kind of error are we talking?
Maybe missing a third molar is not part of the optical scan, segments getting pushed together when there's not actually space for them to be pushed together.
Oh
You know,
yeah,
like
if you're it's like if
just
you're getting
engineer
into the weeds
errors.
with well, I don't know if error is the right word. I wouldn't go that far.
I wouldn't
Man,
blame the engineer. It's just that, it's a human doing something.
well,
So
it's
there's
like if
going to
you're getting in
be
the weeds with an
wrong.
occlusion and they're like, all right, scooch. There's sometimes they're saying orthodontics gets on. You're getting into the weeds. They're like, all right, scooch that canine forward, get into class one. You're like, okay, done. And then you're done with that. But after the fact, once you get to the R, you're like, hey, you ran these segments 4 millimeters into each other, and the tooth roots are now crossing each other. That's not going to happen. But what are you going to do?
Yeah, but I mean, you're better at planning now than you were 10,000 cases ago,
Yeah.
right?
Yeah, it's all
What,
those
what
little
have
things
you
like
noticed that you're better at picking up on now?
Oh, things like that. Maybe looking at how different segmental osteotomies it should like change symmetry and occlusion, and then looking, you when you start treatment planning, you look at the numbers, right? You look like, all right, cant is this, and gonial angles are that. We're gonna get those perfect. When you zoom out, big picture, like, okay, you have different ramus morphologies. Just because the number that's arbitrarily picked at the gonial angles, and you guys treatment plan your own, like you're probably not going to get that point exactly the same left.
I don't think everyone knows
that
that point. I'm on board with most people not understanding that.
Yeah.
What
So
do you
it's,
think
it's
about
like
that, Watson?
one's plotted medial,
100%
one's
agree.
lateral. Like it shows a 2 millimeter difference. You're like, okay, let me correct that yaw. So you correct the yaw, but then you look from the front and you're like, oh, that's not right. Like the numbers say it's right, but it's, you look at the jaw and it's not, that's not how it should be corrected. So it's kind of like getting a big picture of kind of facial balance that independent of the numbers is something that really, unfortunately, just comes with time. But even from a surgeon perspective, like you
It
guys see
kind
a
of goes
face.
back to our argument of you don't need a ceph tracing, Sam. Like
No, you need a
just
ceph tracing.
you
Ceph
don't need
surgery.
it. You don't need it.
I'm gonna say I'm somewhere in between your camps. It's
I
funny
mean,
how
I'm not like, absolute everything in ceph, but cephs give you some good info.
They do. They do. And the problem that I run into is there are times when I need it or I want it, I guess I should say, and then I don't have it. And it's like, well, it would be nice to have this information now, but that's off topic. Anything else you can think of, Evan, that people would maybe want to know from an engineering perspective or that would be helpful? While you're
nothing's
thinking, I think this is a good point to reiterate, Sam. You and I have talked about this mostly when it was other topics, and we've even kind of glazed over it a little bit here. But I think the other thing people don't know is just that you guys, as the engineers, are doing the best you can to set the STL file, the occlusion to the CT scan, and it's not perfect. And you're just getting the best fit that you possibly can. Do you feel like when I play around with it here, and if anyone's actually watching, I'm that's the step I'm trying to do now is set this STL file to the CT. Are there tricks or tidbits, or do you feel like there's a difference in that process between engineers?
I don't think so. I think the bigger I don't know if I'm gonna say problem. We have people that do this day in day out, and they're, in my opinion, quite good at it. Or not we. I don't work there anymore. They have that. But the bigger problem is crappy data. If you take the CT and intraoral scans in your office on the same day, I almost guarantee you, and it's a good CT, there's no movement. I guarantee you that alignment is going to be 99.9% accurate. Now, if you take a CT in January and you get intraoral scans from your orthodontist who you're not really sure when they took those, and there starts to be some subtle movement between those two things, that's when it's you kind of have to guess on what that best alignment's going to be. And
What
I
are
think
the,
You think it's that accurate? Because even like when I'm setting it here, you go to this auto superimpose, and a lot of times it's a millimeter or more off, and you can try to tinker with it, and it's you're thinking it's you guys as engineers are getting it much closer than that most of the time.
would say yeah. I would
Huh.
say yeah.
he's
I would
saying it's
say it's
dependent
close.
on the
It's close.
data.
Yeah, but
Yeah,
yeah,
absolutely. The data
if you have
matters.
perfect data, I think it's no problem. When you start to run into old scans or old intraoral scans, or someone that has veneers, or someone that's a edentulous or something, then
So
and
I
we'll
mean,
go in.
like, look at my screen here. This is the best fit from auto superimposition, and it's 1.24 millimeters off.
Yeah, and
So
if you zoom into the CT scans and look at the contours and start tweaking it from there, I think it's
okay.
for as many cases as I have treatment planned, we have people that have done more than that, or they have people that have done more than that for superimposition of dental models to CT scans.
Hmm. All right.
And so the current guidelines on occlusal level data is 6 weeks or 2 months. Like what do they? Is there a
So.
formal industry standard on that?
Occlusal data is hard because there's not a timestamp on it.
Sure.
CTs, they come kind of built into a CT is when the scan study was done. So it's like I can tell pretty easily when you took that CT scan 9 times out of 10. But
And
intraoral
6 months on the
scans,
CT scan.
yeah, 6 months on the CT. Intraoral scans, I mean, as a kind of a general rule, I feel like I've heard 4 weeks is pretty safe.
It's
I mean,
obviously
obviously longer if they aren't orthodontics and have not been orthodontics. That's a
sure.
different ballgame
Yeah,
altogether. But you never really know. Who knows?
yeah. Because I mean, I feel like, and then I might be misremembering this, but I don't feel like there's great data on that. I feel like it's just very much like, what do you think is right?
Yeah.
And obviously you don't want any tooth movement, but at the same time, I think there's tooth movement.
Yeah. Oh yeah.
So
Yeah.
generally a month, 6 weeks, something like that.
Yeah.
Got
Yeah.
it.
Man, I'm much more diligent and careful with my data. So do you think it's safe to say, because I try to get them really close and accurate? Evan, do you think it's safe to say that most of the engineers I work with probably really like me?
Yeah, I'll tell you, having good data makes a world of difference on the industry side. It's like having a good CT scan and having good optical scans is like nearly
But
cuts in half processing time and makes everything smoother and just
but
yeah.
from like a purely likability standpoint, what rumors do you hear about who's more well liked between Dr. Bobek and myself?
The mustache helps for sure. For sure. Yeah.
Would you think he would be looked at more favorably if he employed the makeup artist that was
Absolutely.
suggested?
Absolutely.
Yeah, I mean, I think outside of the face hair discussion, I think what I generally think in terms of 3D planning is like Evan understands where the inaccuracies are in terms of the data, the STL, the DICOM, all the engineering side, and the clinicians kind of understand the surgery inaccuracy stuff. But now that people don't do model surgery and they don't do their own 3D planning, there's no one really that understands the whole thing, right? Like back in the day, you understood why 3D planning had errors in it because you did it.
Mhm.
And you understood that model surgery had errors in it because you did model surgery. And you realize Facebook transfer isn't all that accurate. And alginate can influence the quality of poured up models. And I think the same is true with like optical scan quality and CT quality, because I mean, at least in my clinic, that's all done by the assistants and it's just uploaded to the company. And if I was just a planner where I jumped on with our surgeon that jumped on with the planner, and I didn't see any of that data, you know what I mean? I think what you would take for granted as us knowing about isn't necessarily what we know about.
Yeah, and then there's kind of this hard gray area where you get a CT scan, you get some optical scans, you marry the two. Yeah, they're 4 weeks apart. They're like, okay, is this dental movement? Is this a warped intraoral scan? It's only about a quarter millimeter different. You can't really be sure. And where do you draw that line of, hey, we need new optical scans. Hey, these aren't going to fit when you go to surgery next
Totally.
week. There's no black and white rule. That's for sure. It's if it's within a certain threshold, it's probably good, but I don't really know.
So what's the fix? Like, I mean, what's the way to optimize this as much as possible?
If you can do both in your office on the same day, that's
Yeah.
as optimized as you can get, in my opinion. And
So
within, let's say, within a month of surgery.
let's even take it more big picture than that, because to maybe summarize some of the things we've talked about. So in your shoes, Evan, if we sent what photos would be useful for you to get? What information would you want on the planning sheet? Yeah, let's just presume it was possible to get the digital scan and the CBCT the same day and sent quickly to where it's not a rush. You're not like, oh, I have this case on Thursday and we got this on Tuesday. Let me send it off and turn it around. What other information can surgeons send you that would be helpful? Like, what would you want? Because I always assumed, like, if I was sending photos and all this stuff, they were going to just think I was crazy and they weren't going to use them, and it was going to be a waste of time. Like, are there other things that people should consider sending?
No, I think you kind of hit it all. So like repose, smile, lateral, lateral and repose, kind of the big three, if you will, and from a like treatment planning perspective. Impressions, in terms of an order form, if you don't send one at all, it's arguably better than sending one with the wrong information, because you will take a look at it and be like, oh, yep, this is narrow. Let me fiddle around to see how I can set this as a multi-piece. If you say, yep, I'm doing 2-3 cuts as a 3-piece, it's probably going to set up as 2-3 cuts as a 3-piece, whether or not that's the best occlusion. Um,
So you're saying if you don't specify where the cuts are, the engineer might actually do a better job because they'll tinker around with it more and
Potentially.
yeah,
If
huh.
you say 2-3 cut 3-piece, it's almost taken as a fact that that's what you as a surgeon want to do, and that's your surgical plan. And you've looked at this beforehand to optimize it yourself, and that might not be the case.
Huh. I think that's interesting. I think that's a really interesting piece of information that people don't know that could be improved upon. What do you think, Sam? Do you have anything else you'd add to as far as like how else it could be made better?
Yeah, no, I mean, I feel like this flexibility and this idea of more creative planning or using even the plan to help you out in surgery. Um, I guess I'm surprised that it just isn't done more, because I don't think there's a formal right answer to any of this. So we can play with it a little bit. So I like the idea of engaging the engineer and having them be part of the team and the plan. Did that
We
answer your
need,
question, or am I in my head somewhere else? I wasn't
yeah, I
sure.
mean, you kind of did. I
Okay,
mean,
sorry.
And what's interesting, bringing it in house a little bit, is either you're doing it yourself or you're working with somebody who has access to the patient history and the exam notes, and you can see what that patient's concerns are. You can look at their photos. You can do all this
I'm
without even talking to the surgeon, right? It's like you can know all this beforehand, and then more or
I,
less.
yeah, I think we're on the same page there, and we're probably all three on the same page that in-house is the right way to do this. I think in the next step is just going to be automation of these things. So, once we get some smarter computer programs to help us out with this, I mean, do you think they're going to be able to replace engineers on this stuff, Evan, or no? Like the stuff we're not just describing, probably not quickly, but the steps before the engineer.
Oh, I would imagine so. At some point, that's going to be all automated, if
Like
not
the
already.
steps
We just don't know.
before the engineer are going to be automated, right?
I would imagine.
Um,
Yeah, I couldn't tell you what industry's doing now, but if they're not there, they probably have that on the roadmap for the next few years.
got it. Um, and then the in-house planning discussion could be for another day.
okay,
Yeah, because it's going to get long, because we've been talking, I think, enough time on this one.
probably.
Yeah, Evan, I appreciate you coming on, man. I think when it
Yeah,
comes to
thanks.
these topics, I don't know, I had the opportunity to go to the previous company that you worked at and see the inner workings of engineer life and see like how data flowed and, like where the splints were made and all that sort of thing.
It is a pretty cool facility. If anybody ever goes to see
It's a great
any,
facility.
any of their vendors, I think it's just interesting to see what goes on behind the scenes.
Run really well. Like, I don't have anything bad to say. It's just, I just kind of took a lot of that for granted, like how the sausage is made. Did I use an old man saying there? Is that a good one or no?
You went somewhere, but I don't know if that's where you wanted to go.
That's an appropriate one. I didn't mean it that way. I just
I didn't take it that way, but
yeah, anyway, the old man sayings, you kind of drop the ball on that one this time, Wasson.
Yeah, I was just really trying to get as much out of Evan as I could with some of this stuff and keep it on a level that maybe people would appreciate instead of being out in left field too much.
Yeah.
Hopefully we were successful in that, but who knows?
Yeah. Well, yeah, no, thanks a lot for coming on, Evan. Appreciate it, man.
Yeah, thanks, Evan. And as always, that was another thrilling Down Fracture podcast for Talking Jaws. downfracturepodcast@gmail for suggestions or complaints or humorous anecdotes or old man sayings are always appreciated. We'll see you next week.
All right, next week.
Thanks. See ya.